Morning. My great pleasure to talk to you again for the second year in a row. I'm very pleased to be here in a city that I made so many friends. This is my service in south of Brazil.
Release sound, please. Sound.
Hello. And we travel 11,000 kilometers to be here. It's such a long trip, but it's fun. And this year we came with 3 other colleagues from our service. I'm going to address to you a very hard topic, management of the first time shoulder dislocation and where we are today. I have no conflicts with this presentation. And tell you the truth, this is how I feel speaking after all those great speakers and thinkers. You did so well this morning presenting your experience and your thinking. And it's a very kind of dangerous road to speak again after you. Very easy to understand. No slide, no talking is necessary. It's a big head and a small glenoid and very loose ligaments. Well, this is very easy to dislocate, as we know. And once it dislocates, just one single episode of shoulder dislocation makes a buncard lesion. There is no way that you will have a normal labrum after the first dislocation. More than that, this is the place where dislocation takes place in 98% of the cases. Anterior, inferior glenoid rim. And believe it or not, 96% after the first time dislocation, there is a buncard lesion established. Well, so here come some questions. Which patients will benefit from surgery in the very first episode? Which patients will not benefit? Shall we consider surgery in all cases of these first-timers? And then, big question, arthroscopic or Latarjet for the first-timers? And there was a long discussion this morning about this. This is not new in the bibliography in our field. In the 80s and in early 90s, when arthroscopy was at the beginning, there was already papers discussing this. So this is not a new thing for us. These 2 papers talk about the military in the United States, and the numbers show very well that when this group of patients didn't have surgery, 92% of recurrence rate. With arthroscopy in those days, only 22. Well, and then this other paper from Arciero, big guy in those days, showed that non-operative 12% recurrence, and with arthroscopy much less. Well, and that was stated many times this morning. Bone loss is the key, either in the glenoid or in the humeral side. According to every single paper, when the number of dislocations increase, the bone loss increases. And it was so well addressed by Kevin Plancher here in this podium minutes ago. And numbers again come to establish this. First time dislocation, there is an average of 6.8% of glenoid bone loss. When it becomes recurrent, raises to 22%. That dangerous number that needs bone block procedures. Now let's talk about non-operative. That was the question I addressed to Blanchard minutes ago. And I like this paper. It's an old paper, but it says something that it's important to remember. 250 patients, 25 years follow-up. It's not just a small paper. It's 25 years follow-up. All treated non-op initially. In those days, 2008. So these patients belong to the 10 years before, I guess. 7% of those had one recurrence. 50% several. However, 43% never had a recurrence. And this is a big number, 43%. So this paper tells me the Hippocratic oath, primo non nocere approach, telling that, well, we should not do surgery for everyone. Then we learned with this paper that the younger the patient, the greater the chances to require surgery. And everyone has repeated this statement. And the older the patient, the greater the chances of one episode only. The older means more than 40 or 50 years old. Well, age as a cutoff limit, and this is important. Active patients in their 20s or 30s, surgery would be advised for most of them. However, in the older patients, older means around 60 or more than half of those patients have rotator cuff tears associated. Then, detection and the proper correction of all lesions are the key here in this group of patients. Now, remember when A.G. Toy brought this new concept of immobilizing in external rotation. For the veterans here, for the older surgeons, we remember when this patient came out. Immobilization of the arm in external rotation is better approximate the punctured lesion to the glenoid neck than does the conventional position of internal rotation, leading to healing. Well, and then several other papers were studied just to check this. And this paper, 20 years after, from the German guys said, well, we didn't see difference in the clinical scores, but recurrence was much higher in the conservative treatment using immobilization. And surgery is recommended in younger than 30 years old who are active in sports. And this algorithm shows that using only conservative treatment with the external rotation, 19% recurrence. With arthroscopy, only 2.3%. So, keeping conservative or internal or external rotation doesn't give any good for the young patients. And then comes the ACEs, American Shoulder and Elbow Surgeons Near Circle Consensus. And I participate in this study. They try to understand the decision making in treatment in the first time dislocation by Delphi approach, which is the opinion of leaders. Here are the main recommendations after this study. They recommend surgery for contact athletes aged more than 14 to 22 years at the end of the season with both apprehension and meaningful bone loss. Would not perform surgery after first dislocation in patients who are not athletes without apprehension and meaningful bone loss. Number 3, do not believe surgery should be the standard for all first-timers. 4, strong recommendation to surgery where apprehension and meaningful bone loss is present. And age distribution, less than 14 years and more than 30 years were less likely to have recommendation for surgery. And now comes the big battle, arthroscopy or bone block. We hear great papers this morning about this. Well, I won't repeat, but in many comparisons, Latarjet group had a very low, near zero recurrence rate. And this is even in the collision athletes, and this is great. EASIS score that was brought by Pascal Boileau, it's always, you love it or you hate it. And this paper with almost 5,000 shoulders says that EASIS score is very important. Those are the risk factors for recurrence after your arthroscopic Bankart repair. Age less than 20, competitive sports, heel sacks, off track, bone loss, ALPSA, more than one dislocation, and EASIS more than 3. Here again, when you have 15 to 20% bone loss, you should do a Latarjet, which the recurrence rate is much less than the arthroscopic Bankart. Well, answering the questions that I made at the beginning, which patients will benefit with surgery in the first episode? Youngsters, most. And the ones that practice sports, and it was so well described by Kevin Blanchard minutes ago. Which patients will not benefit? Old patients. Shall we consider surgery in all cases of first-timers? No. Wait. Arthroscopy or Latarjet for the first-timers? Well, that depends, and we have to think. There is not a very clear answer for that. I want to, again, invite you for the 15th International Congress of Shoulder and Elbow Surgery that will take place in the beautiful Rome, the Eternal City, in just few days, September 5th to 8th. And this is a great meeting, more than 2,000 shoulder surgeons from all continents in an organization of the International Board of Shoulder and Elbow Surgery. And thank you for including my service, Institute of Orthopedics and Traumatology in south of Brazil, as participation of this meeting. And of course, thanks to Professor Adel, which is a great man behind all this. And please be in touch. It's going to be a pleasure. Thank you.